I mean, thinking about how Global Fund thinks about sort of core principles and key stakeholders, I think Global Fund investments are led and owned by national by programs. And it goes through a process where sort of a really very country-driven, coordinated, multi-sector approach involving all the relevant stakeholders. And I think from the panel we've just heard previously, communities are a key stakeholder and part of the Global Fund funding request process. And so I think we sort of really very strongly feel that only by this multi-sectorial approach and letting countries sort of drive and own where they think the investments should be is a really sort of key principle. And going sort of, the Global Fund has obviously invested for the last 20 years in TB, HIV and malaria, but also the community and health systems behind those programs to try and create the sustainable systems for health, which will go on to help countries achieve UHC, which I think is this, as we've talked about previously, that's where the integration sort of really can and should happen. And so going forward in our new strategy, that supporting resilient systems for health amongst our 3 disease programs, rather than as a separate silo. There's not an RSSH silo, it's embedded within the three programs. And in the next 3 years, we're actually investing $6 billion USD in RSSH activities, which represents a third of all of the funding for the next cycle. So I think it's really seeing the importance of that. Then with sort of regard to the integrated financing, Global Fund has worked with a lot of blended financing with mainly development banks, particularly the World Bank, but increasingly other regional development bank. And I think it's really important to ensure that there's complementarity of the strategies and that you're working to mutually agreed health outcomes with the countries sort of clearly involved to strengthen the alignment and harmonization and support common goals. I think those are sort of really very key parts of when we're thinking about integration, who our stakeholders should be, and that common understanding amongst all the partners what the common health goals can and should be.
Thank you so much, Grania. It takes everyone to collaborate, isn't it? Bent, the same question as well.
So before I go to the question, just a big message of gratitude to partner with us on this event. As my colleague Sanne explained, we were selected at the UN high-level meeting plenary last year to speak, make a statement in the official hearing, in the official plenary as the only NCD voice, I suppose. And that was a culmination of many years of hard work in terms of the advocacy, of course, but building on our on-ground experience. And when I went out of the plenary hall, I met Morten, where are you, there, from FIND, who had also just spoken. And I think maybe it's because we are from the same country, I don't know, but there was a kind of I don't know, telepathic link that this must be it. And since then we have discussed how to organize this event today, and here we are, full room. So it must mean we are onto something right. And that takes me to your question, Blessy, around who are the core, which are the core principles, and who are the core stakeholders. I mean, the core stakeholders are here in the room, at least when we are in Geneva. But the real core stakeholders are obviously those who work on ground in the health systems all over the world. Those who are at primary facilities, those who struggle with daily clinical management and have one patient with multiple conditions and the lack of resources and time and all of that. There's a concept or a theoretical concept called path dependency, which is used in many disciplines of science, which is your dependency on the path that you're walking on and your lack of ability to move away from that path. And the longer the path you walk on it, the more stuck you become. So I think we have to move out of that path, that dependency of siloed health systems. And that's not only TB, it's all of us. Even the way we started our work in WDF as a philanthropy, of course we are small compared to others, this was a little bit the same. We are also on that journey. So that takes me to that's the principle side of it. We have to break that principle into a new paradigm of one health system. And that's not easy. The equilibrium between epidemiology or population-based, you can say, assessment, health system capacity, and the resourcing, that equilibrium between the three is not easy to make. But if there's a point in time where we have to make it, it must be now. I think Dr. Mikkelsen said there's a tsunami on the way, diabetes, hypertension. It's not even on the way, it's just right in front of us. So we need to find those ways. So this meeting today, I don't think it's an opportunity for FIND and WDF, it's an obligation to meet like this. And philanthropy is definitely ready to co-invest, and we've done so already. We try to find ways with much bigger agencies. Sometimes catalytic funding can make a lot of difference. So this is obviously an open door to the Global Fund and World Bank, and who have you. Can philanthropic funding make a difference to kickstart or really roll out at scale, as we've seen in some places already, we heard from before, but doing it nationwide? I think Bente said, should we find 6 countries before next year? Let's find much more than that. And I think those were my initial remarks. Thank you.
Thank you so much. I like that. It's an obligation. So it's almost like it's not a choice. Adela, to you, the same question. So we're looking at the core principles and the key stakeholders to scale effective integrated financing.
Thank you so much. Let me start by thanking for the invitation. As you mentioned, I'm from the Africa Center for Disease Control and Prevention. We were just having a launch of one of our flagship initiative with some Minister of Health, but I felt that it's important for me to be here. The 2 previous speakers, Bent and the previous speaker, have made our response easy. Ben alluded on the need really for One Health. Here we are talking about integrated chronic care management, but we need to look beyond. And at Africa CDC, this is what we are really advocating, looking mainly at developing capacity at the country level. Last week I was in the Kingdom of Lesotho. For those who know, it's a hilly kingdom in South Africa. And we went there for a peer assessment with 2 other countries, Botswana and the Kingdom of Eswatini. And we were really shocked to see the excellent progress that the country have made in responding and controlling the HIV and TB, because it's also a country with a high rate of TB because of the mine and stuff. And we were also shocked to notice the partners that are on the ground that have been working in this to help the countries and that are willing to support the countries. But in all the conversation, all the consultation that we had, it was the fact that there is a lack of leadership, particularly for the NCD program. And this comes to respond to what Gladwell was mentioning about the siloed program. But sometimes it's not only funding, it's also lack of leadership. And this is something that we at Africa CDC are taking very seriously. And that's why this morning we're launching a continental mental health, but also very soon NCD leadership program. And on the key stakeholders, I think the previous speaker has also mentioned about it. It's a multi-stakeholder way. And for me, let me highlight 2 maybe stakeholders that we need to have. We know there's the private sector. Africa CDC is a member state organization. They've already talked about state, but we need also to work with private sectors. They have the expertise, they have the knowledge, and we need to engage them in really public-private, partnerships to ensure that whatever we are doing, it's really coming to strengthen health program that will improve the lives of our communities. And lastly is that the communities for which we are doing everything that we are saying here. And in some countries, they are also, contributing in the health financing, because NCDs are still paying out of pocket. So they need to be convinced, they need to be educated so that they can also do their part. I think that's, I'll pause here. Yeah, thank you.
Teresa, the same question, core principles and the key stakeholders.
Okay, thank you very much. It's easy from one side to be last in the line because we're all following the same principles, but it's also a challenge to bring something new. But I would like just to highlight a few things that we should really put people in the center and communities in the center, and we should do it in reality. We should move from the declared principles to the working principles. This is one of the biggest challenges. We are very good at presenting, describing, but facing challenges in implementing. Then, as a WHO representative, it's not surprising to expect it from me that we should follow in our the approaches latest research evidence, and our guidelines should be agreed, supported, and based on the latest evidence and research. Another principle, maybe agreement before we decided to take this journey together, to have common understanding of, first of all, of integration, because there are a lot of confusions and a lot of different interpretation. When one person, one healthcare worker or community worker is doing multiple things, even sometimes not having enough capacity, it's not integration. When we are trying to centralized services driven by the intention to do it provide integrated approach, it's also not the right way to integrate. So this common understanding of the principles at the beginning is absolutely mandatory. Then we should be open-minded, because if we will build different partnerships, diabetes, TB, mental health, TB, HIV, TB, so I don't think this is also the right way. We should open our doors, and once we will establish some good practice, we should be ready to bring others, and then we will definitely follow this people-centeredness. And maybe finally, we should not forget about some good practices that maybe already exist. We are not necessarily starting from the scratch. We should carefully learn the best practices and take good lessons and bad lessons, and then we'll have much more chances for success.
Thank you very much. What a great opening statements from our panel. There are two questions each now to each of you. We'll go one round of first question and then the second question. And someone is keeping time and will be showing you how much time you have left. So I'll start with Grania again. So you might have already touched the answer to this question, but if you can also elaborate. So how does the Global Fund approach this integrated financing? And what are some of the lessons that can be learned from the Global Fund's funding for integrated service delivery programs?
Thank you. Hopefully it's working. Yes, I mean, I think the Global Fund sees it as we use the term blended financing as but I think it's really seeing it as an opportunity for complementarity, not duplication, and really sort of seeing how working with other funders can blend in with the Global Fund grants and really leveraging the respective benefits and strengths of the Global Fund in some and then the partners we work with. So really sort of looking at partners' country presence, building fiduciary and operational expertise, continuing to strengthen the national institutions and processes, because that's key to the sustainability of all the investments, both from Global Fund and from other partners. And I think we see for TB and diabetes, TB and as Teresa said, sort of TB and other comorbidities is sort of how can these blended finances sort of embed these things within the broader health systems, so the NCD, the infectious disease programs, all working together to really go for a UHC approach, and keeping that expertise at the central level, but with the mutual and complementary investments in the systems, such as lab systems, supply chain systems, HRH, and integrating through those areas, really kind of helping sort of everyone achieve their overall outcomes, which from our side is obviously ending TB by 2030. So, and just sort of some of the examples. So Global Fund has done nearly sort of well over 10 blended financial agreements, mainly with the World Bank, but sort of, and sort of some of the examples could be, so for example, in India, Global Fund invested $40 million to help India secure a $400 million loan from the World Bank, which was specifically to fight TB. And then there's also been blended finance agreements with the World Bank in Pakistan, focus on strengthening primary care, but with the Global Fund sort of, as I was saying earlier, those mutually agreed health outcomes, of which TB, HIV, malaria, and the diseases that put you at risk are part of that. Again, there's been another piece of work in Indonesia where the TB-specific health program complements the health system investments in the nutrition and early years program. And so the Global Fund, working with the Gates Foundation and the World Bank, have developed a blended results-based program, which has leveraged funds from the International Bank of Reconstruction and Development to support the government of Indonesia, which also committed to increasing its domestic spending in health. So these are all ways of strengthening the system for integration, but also, I think, in the longer term, the sustainability and supporting countries with the domestic financing to ensure that we continue to make this sustainable from donors. And I think just the other thing is as well as the World Bank, the Asian Development Bank has recently announced a $1 billion investment in TB, which Global Fund will work with them on how that is realized.
Thank you. Ben, can you define for us integrated financing? What does that mean? And give us an example of what this looks like in practice, and how it can help address some of the funding gaps that are there in order to deliver better care. A lot of questions in one.
No, it's fine. Thank you so much, Blessy. Yeah, I believe the way we are discussing even now shows us the work we have to do with the concepts, integrated financing, blended financing, innovative financing. That's maybe for another panel. But it is important to be advancing these concepts, because they will then, guide our actions. So I don't think I can come with a final definition for all handbooks today on what integrated financing is, but I think I would emphasize that by its very term, it's about integrating streams of resources. So I think it's probably more interesting to start defining these streams of resources and see how they can converge. I think one term that we try to advocate a lot in World Diabetes Foundation is the convergence. So convergence of agendas, convergence of health system modalities, and obviously the underlying and very critical convergence of the financing. So one definition of integrated financing would definitely need to incorporate that thinking of convergence. And just before I move on with financing, we are not a medical agency, World Diabetes Foundation, but we work with countless clinical experts at the highest level, at country level, and in so many partnership countries. And it looks to us, and the feedback we get, that there is still need for more technical normative guidance about integrated care delivery. What does it actually mean in practice? And surely there will be many in the room who can bring details to that, but taking it to that next level, SOP, practical guidelines for primary care, would seem to be still in need of more work. We heard about the TB area handbook. We also know from our friends in the NCD department that there is a lot of work ongoing, but we just see from our country and get the feedback that how do we actually do it in practice? And I mean, this is not new. The collaborative framework for tuberculosis is 10, 12 years old. So where have we reached? And before coming today, I spent some time reading the recent macro reviews of research, and it looks a little bit to say the same. We have tried some pilots. Some countries, we heard from Mr. Sanjay before in India, of course, some places we do see progress. But how do we compile it and consolidate that into more practical guidelines? And here I believe also the WHO regional offices has a strong role to play. But going back to the financing and, well, linking it to that, because the way then this converging financing should be designed will of course be guided by those practical tools at the end of the day. And that's still, I think there are some missing pieces there still. It's impressive to hear the figures you mentioned before, but how far will they take those processes? That was still, I think, a question for all of us looking in the forward. The final thing, financing is of course also for the individual. I mean, we have wonderful advocates here chairing the session. But we heard also from Bente before about out-of-pocket expense. That's a term you can see over and over again when you are in the NCD community. Out-of-pocket expense, OOP. It's everywhere, unfortunately, still in the NCD area, whereas in the other sections, like TB and HIV, well, the access to medication has been at a very different level. We'll have to look at that somehow. We can't let that matter become an elephant in the room, because we need to find a way to move the needle. Thank you.
Adelad, for you, tell us about the Africa CDC's NCD strategy, and how does integrated care factor into this strategy? And I'd request you to be really quick, because we have one more very important question for all the panelists, and we're running short of time. Yeah, over to you.
Thank you so much. I will really try to be brief. So I will start where not many people knows that the idea of having an Africa CDC came in 2013 when we were having an African Union summit on HIV, TB, and malaria, and but a division to work on NCD just came in September 2020. We're in the mid of COVID, so we had time to learn from HIV response, COVID response, and talk to anybody, because we knew there's a lot of players in these areas, and we need to understand what are Africa CDC comparative advantage. We are the African Union Public Health Agency. We have the political side with us, with really convening power, and we are looking at how can we leverage on that. Somebody have mentioned this, and this is the approach that we are using, and today I'm happy that we are starts working soon with World Diabetes Foundation to Again, look at how countries that have made progress on this can support others by having center of excellence. When you talk about integration, it's a magic word, but what does it mean really, and how can we scale up those successful model? And we need countries that have made progress to support others, and we want really to pilot this concept with some region and then see how it go for other region. The other area that I wanted here to highlight is multi-sector coordination, and at African Union we've established a multi-sector task force that is the first of its kind, looking at the NCD, injuries and mental health, and that's the vehicle that we're using really to support countries. We at the Commission we have the different departments. So if you really want to convene a meeting of Minister of Finance to come and discuss, we use it, and we have been able really to convince the chairperson, the top leadership, to be part of it. And I'm glad to also announce that during the mission, the assessment we did in Lesotho, we used this multi-sector task force. And the last area that I want to mention, the strategy is available online if you go to our website. The last area that I want to mention is the access to health products. Other previous speaker in the last panel, they mentioned about it. And at Africa CDC, we believe that we need really to push the local manufacturing, and there's a lot of opportunity for NCD medicine, diagnostics. And somebody also mentioned, when it comes to new treatments, new products, Africa CDC is Africa, the continent, is always lagging behind. How can we really address this? And I think local manufacturing, food procurement for Africa CDC, the way to go. And lastly, it's what people were mentioning about developing capacity, workforce development, and research. It's very important that we now link the research to really come and answer some of the questions that we have in these particular areas. Yeah, thank you.
Thank you so much. Teresa, what guidance and tools does WHO provide to support the planning and resource mobilization for comprehensive services for people with TB and diabetes?
Thank you very much, Blessy. Colleagues, I would like to start with a few highlights. First of all, you can download Global TB Report. It's one of our famous tools. Through the App Store, you will find it for free, and you will find a lot of useful information, including on the diabetes for more than 200 countries, TB and diabetes. So this is one important tool. Then I would like a bit to use this opportunity to demystify a few things and to clarify. First, our the framework on the TB and comorbidities was released last year, and the older document to which colleagues are referring, it was just focused on TB and HIV, and we've expanded. We're building on this approach, very successful story. We're now covering multiple comorbidities. Then a simple math task. Our global target for TB funding is 22 billion, as it was committed annually, as it was committed in the political declaration. Currently available are 5.8 billion. Less than 25%. Out of this 5.8 billion, more than 4.3 is coming from the domestic resources, mainly from BRICS countries. The rest coming from international funding, of course, with the recognition of Global Fund as the biggest. Almost 50% of people with TB are facing catastrophic costs. If in the current financial situation, following our goodwill, we will agree to integrate and include in the planning also addressing important comorbidities, we have chances to succeed. So of course not. Then we will be put in front of the situation what to choose: treat diabetes, treat TB, and Currently, we are even have to make the choice, provide preventive treatment to the household contacts or not, because of lack of funding. And that's why fundraising is absolutely must in the current situation. We should not have illusions that only following our goodwill for the integration, we will achieve expected results. So for this, we have all the necessary guidance based on the latest evidence. We have framework, we have multi-sectoral accountability framework, strategic document. We are about to release updated guidelines on TB and diabetes, and we have a very important tool for programming all our activities, updated guidelines on the national planning, integrated health tool. It's economic tool that allows carefully cost and prioritize with looking forward for the impact of your investments. And all these tools could be used and will help you definitely to do it properly. Thank you.
Thank you so much. We have 3 minutes left and we have one question, so 30 seconds each. Grania, what made, you talked about global fund integration and blended financing. So what made this implementation successful? Maybe 2 examples very quickly. Thank you.
Yeah, I mean, so I think it's, sorry, the integrated financing, I think, is this coming together of realizing that we really need to, as well as investing in specifics, because there are specificities to the TB response, the HIV response, and the malaria response. But there are also these health systems that by sort of understanding that Global Fund and other partners who are investing in health systems with a different angle, by coming together and combining rather than competing our resources and using them in a complementary way. And I think sort of there was a comment made earlier of sort of within Global Fund, we are moving more and more to sort of building these resilient, sustainable systems for health, which are really incorporating the comorbidities, the co-infections that we're dealing with, and trying to shift away from a siloed intervention to a more integrated, people-centered approach. And I think that's really, and looking, for example, there's a machine in the back where rather than just investing in a TB diagnostics, let's make the call to manufacturers and developers that we want diagnostic platforms that can help for more than one disease, supporting mobile clinic outreaches. Global Fund's done a lot of work in that, of sort of a little bit was before COVID, but COVID accelerated that, taking the services into the community using tools and that can screen for TB, diabetes, hypertension, digital chest x-rays and CAD can pick up other diseases, thinking about post-TB lung health. So it's really keeping the specificities we need because for the diseases, but where appropriate, integrating into a much more UHC approach. And I think just to make a point to raise this, I think the other big elephant in the room is that TB needs more resources. So Global Fund absolutely supports TB diabetes requests within their grants, but there is a financial pressure, and I think we all need to be advocating for more resources for TB and UHC health programs, so that we can really do what we all want to do in the room, which is move towards this person-centered, holistic approach over the life course.
Thank you so much. Bent, I'll come to you. So what is the World Diabetes Foundation? What's your approach to this integrated financing? And what are some of the innovative financing methods that can be used for integrating TB and diabetes? 30 seconds.
Yes, I'll pick up from these very encouraging remarks, although maybe it's a second elephant in the room, but it's also a call upon us who have been in the NCD area for a while. We are trying to unite, in fact, under the Global Diabetes Compact as well, that was highlighted by Bente before. We are more and more agencies, philanthropies, seeing the light as well. We will also need to unite to build a volume and an approach which can actually be compatible with some of those streams that have a longer history, and where the needs are still there, we definitely recognize. So that's, I would say, the more blended financing or joint investment, alliance investment component of our approach, as per your question, Blaise. The other, you can say, is the more innovative, where we try to maybe see if the philanthropy sector can be a bridge with the private sector. These are still relatively new concepts. We have worked with some partners like Access Accelerated and their partnership in the World Bank. Are there new possibilities of leveraging private sector finance into health system, public health programs some way? I think this is still very important, and the need is there. Yeah, and thirdly, we will remain, of course, very faithful to the mission we were given. Philanthropy has a mandate in itself, but it's driven by our actions. There's not a global resolution on the philanthropic section. We have to ensure that we maneuver according to global and national policies, but very much engaging with lead agencies who have been setting those path dependencies that I mentioned before, and maybe we can build a new highway together towards UHC. Definitely, that's the only way forward for all of us. Thank you.
Thank you so much. Adelaide, in what ways is Africa's CDC leveraging linkages between NCDs and infectious diseases?
Yeah, I think the previous speaker again said a stone. For Africa CDC, we are really working to ensure that our leaders, walk the talk. There's a lot of commitments, but we are not seeing it being translated into actions. And that require, as the other speaker mentioned, communication, coordination, collaboration. And in that regard, Africa CDC is really open, to work with partners, and like we're going to have a session in WHO, see how we can really join forces and ensure that we are working together, really to ensure that we are having progress on these issues, and fundings, and we support effectively our member states. Yeah.
Thank you so much. Teresa, what are some of the opportunities that are there for building the investment case for comprehensive, people-centered services for both TB and diabetes at the country level?
Colleagues, despite of understanding all the challenges, we should remain opportunistic and positive, because first, there is no other way, and evidence shows it clearly, and TB is preventable and curable disease, but still curation rates are not high enough, and one of the clear reasons that comorbidities like diabetes remains unaddressed, and so it's must. There is no other way, and let's try to find opportunities. I can give example. Recently, we've conducted joint mission to one of the high TB burden countries, Nigeria, with NCD program and TB, and we showed case how we should learn to work together. We should try to look at the opportunities, and then we will succeed. So let's work together and let's be opportunistic. This is our last message from myself.
Thank you very much. On that note, let's give a big round of applause to our panelists. Thank you so much.